Good evening, everyone. Good evening, everyone. The academic platform of Maharashtra State Chapter ISA is highly honored today as we have three dynamic and great faculties on this dais of Maharashtra State Chapter ISA. And the popularity of these three faculties is, I don't think they need any introduction because the registrations for today have crossed 500. And in the evening at around 4 o'clock, we had to stop the registration as the Zoom limit was already over. So that itself speaks about the popularity of our speakers. The topics are also interesting. We are discussing it since ages, but still then we have not come to any conclusion. In fact, Dr. Balabhaskar sir has also taken a lead, and we have just listened to him in the ISACON Ahmedabad about the guidelines that he is forming, and the draft is also ready. And the topic is very much related to what we are discussing today. So let us listen from these three great faculties regarding preoperative optimization, cardiopulmonary optimization, and another topic, preoperative investigation. What are the guidelines and what we are practicing actually in day-to-day anesthesia practice. I hand over the mic to Dr. Anita for introduction of faculty.
Yes, it is my proud privilege. I welcome Dr. Jiggy Diwatia, and it is my proud privilege to introduce sir. Actually, he and other two people also do not need any introduction. And Dr. Diwatia is a hardcore teacher above all. And we have been listening to him over past 2 decades. He has held so many top positions at national levels that I will just enumerate his very short CV. He is at present the professor and head of anesthesia and critical care and pain at Tata Memorial Hospital, Mumbai. He has been the past editor-in-chief of the Indian Journal of Anesthesia. He has been the past president of Indian Society of Critical Care Medicine. He has been the president of Society of Oncoanesthesia and Perioperative Care, and he has been the past president of the All India Difficult Airway Association, and he has many more than 165 publications to his credit. So this is a very ultra short introduction of Dr. Diwatia, and because I am sure you all want to listen to him more, so with this short introduction I request Avinash to introduce Madam Anjo Graval.
Thank you, Anita.
Yes.
I welcome Dr. Anjo Graval, Madam. It is my pleasure to introduce her. She is Professor and Head of Department, Dayanand Medical College and Hospital, Ludhiana. Her areas of interest are obstetric anesthesia, CPR, airway management, trauma anesthesia, and scientific communication. Her achievements are she is Vice President, RSACP and former EIC, GOACP. National Secretary, Association of Obstetric Anesthesiologists, India. She is Associate Editor, International Journal of Regional Anesthesia. She is Coordinator, DMCH, AHA training site for AHA, BLS and ACLS courses. She is founder member of Airway Management Foundation. She is Chairman Code Blue Team, DMCH, and Scientific Chair, National ISACON. She was Scientific Chairperson of National ISACON 2016. Total number of index publications are more than 85. So welcome, Madam. I request Samir Soni to introduce next.
Good evening, everyone. It's my proud privilege to welcome to our master class Dr. S. Balabhaskar sir. He is very well known faculty throughout India. As we all know him, he is a professor in VIMS Bellary, Karnataka. He is member of Publications Committee of World Federation of Society of Anesthesiologists. He was past president of ISA National in 2019, past editor-in-chief of Indian Journal of Anesthesiology from 2013 to 2016. He is chief coordinator for formulation of these 5 ISA practice guidelines which we are going to discuss today. He is editor RGUHS Journal of Medical Sciences, that is RJMS. A vast areas of interest, but few are included here, like research, developing guidelines, and education in medical colleges. He has more than 50 publications to his credit. So welcome, Dr. Balabhaskar sir.
Thank you.
I request now Dr. Anjo Graval madam to start her lecture of the first topic today. Thank you, madam.
Thank you so much, respected chairpersons. Special word of thanks to Dr. Manisha Katakar and Dr. Anita Nahete and the entire team of this masterclass up here to give me this opportunity to talk to you about preoperative investigations. What do the guidelines say? And we're still awaiting our own guidelines to come in. So I'll be talking more about the guidelines that are available and published internationally. I bring you greetings from the Anand Medical College and Hospital, the place where I work. Am I audible to all of you?
Yes, ma'am.
Yes, madam. Yes, you continue, please.
Okay. So before I start, this was, I think I read this question up there, and which minimum routine test grid would you like to offer to a 20-year-old ASA1 patient scheduled for incision and drainage? So we have, various hospitals have various grids, so they would like to offer any of these. So this is what has been a question today in the WhatsApp message also. And what if he has the same patient who has to undergo a hemicolectomy? So would your investigations change? And to look into this question, we'll look at the objectives of my talk today. I'll look at the evolution of preoperative laboratory testing. We'll look at the rationale of routine testing versus goal-targeted preoperative testing. Now, what do our guidelines that are present and published in literature have to say about them? And to recognize when preoperative testing is not indicated. Indeed, as we will see most of the times, it is not. Start with a quote by Sir William Osler: full knowledge which alone disperses the mist of ignorance. And that is what has been important to describe preoperative evaluation. A full knowledge of your patient is what will lead us to provide safe anesthetic care. And what we have to remember is that most of the complications that we're scared of and which actually initiate us to do a lot of preoperative investigations basically develop during management of anesthesia because there is a failure to prepare a patient or evaluate a patient adequately. Though in 1940s and 1960s, clinicians elicited thorough history and physical examination, there were only selective tests being ordered at that time to confirm or refute the diagnosis. In late 60s, there was this introduction of the biochemical autoanalyzer, and this paved the way for multiple tests with a small addition of cost. And therefore, there was this dogma of early, frequent, routine testing, not only testing by anesthesiologists, but also testing by physicians as well as surgeons before they came to us. So what do you understand by routine testing? That's so commonly been, when we were postgraduates, we were asked whenever there was a clinical presentation, what are the routine tests that you would order for this patient and what are special tests? So what do we understand by routine testing? Routine testings are basically defined as tests done in the absence of any specific clinical indication. They are basically done to either uncover any incidental asymptomatic abnormality, to identify patients who could develop anesthetic complications, and current times, a lot of medical legal fears, and of course, avoiding surgical cancellation. So that is perhaps one of the reasons that a surgeon send us with the patients to a pre-anesthesia clinic with a whole list of investigations already done. So the question here is routine preoperative testing that I've talked about, is it a problem? And if you look at the data from the literature, the various retrospective observational studies, as well as there are just 2 RCTs that have looked into all this. They have found that it is indeed a problem and a big one, because more testing would mean that there would be some abnormal, some false positive results coming in. And this would actually initiate a chain of unnecessary workup and interventions for abnormal tests, and therefore increase the morbidity from such interventions. They also have a propensity to cause harm to the patient, because we might continue with testing and lead on to some invasive testing also coming in. Of course, we all need to understand that we all live in a value kind of a scenario of today, where we have to add value to our patients' healthcare, and therefore we need to remember that these preoperative testings will enhance costs. Of course, we know they can delay or cancel surgery and provoke anxiety for patients, something that we really bother about. And as I said before, studies have shown that despite abnormal routine tests, surgeries have been performed. And we all know that despite having some abnormality here and there, we do go ahead and do the surgery. And what we need to remember here is that a medical legal risk is higher if a test is ordered and not followed, compared to a scenario where a test is not ordered based on patient's history. So we need to remember that if you are indeed ordering the test, you need to follow up and indeed come to a logical conclusion with that, if medical legal risks are the reasons for our testing. And of course, this is a waste of valuable resources. We have data from US which looks at $20 million being spent on only routine pre-anesthetic testing, a big number. And if we look, as I said, look from the data starting from 1997. This is a data where they looked at 2,000 patients undergoing elective surgery over a 4-month period. And what this found that of the 96 abnormal results, only 10 could not be determined by history or examination. And of these 10, only 4 were of actual clinical significance. And despite being of actual clinical significance, these tests did not improve nor worsen perioperative outcomes. So it goes to tell us that these tests basically are superfluous. They do not influence the surgical plan or the outcome of the patient. And therefore, we really need to relook at them. So that brings us to a question on how should we test. So if we look at the major predictors of outcome, that is of major concern to an anesthesiologist, we have to remember that guideline after guideline and also our enormous clinical experience shows us that patient history, physical examination, the comorbidities which determine the ASA class of our patients, the invasiveness of surgery, and most importantly, the quality of perioperative anesthesia care is what determines outcomes of these patients. Preoperative testing is therefore not indicated until and unless there is a specific reason to perform a test. And we need to remember this dictum that the test will indeed change the time and content of management or mitigate the perioperative risk that we are looking at it. So therefore, we really need to move from routine testing to actually something called a goal-oriented or a targeted preoperative testing, where we need to define what is the invasiveness of the surgical procedure, look at a detailed targeted history of the patient, spend time with your patient, talking to that patient, understanding the comorbidities, the level of severity of those comorbidities, the effect on the functional limitations of the patients, and then do a detailed physical exam on the patient. And based on the information that you received on that, we need to go ahead and do a goal-oriented preoperative testing, which we need to follow up and indeed intervene and see how we can optimize this patient prior to the patient surgery. So if you look at, one of the most widely quoted guidelines, the Choosing Wisely guidelines, and what they basically suggest to us is that we need to ask ourselves 5 questions before we order any tests. Do I really need to do this test or procedure for this patient preoperatively? What are the risks of this test? Are there simpler and safer options? What happens if I do not do this test? And how much does it cost to us? And therefore, right from, across the, almost, I would say, a decade, they have been looking at questions and things that we should be refraining about and optimizing value-added quality care, which is also indeed safer for the patient. So of the 5 things that Choosing Wisely guidelines suggest to us is is do not obtain a baseline lab test in patients without significant systemic disease, that is, patients who belong to categories of ASA 1 and 2, undergoing low-risk surgery. Specifically, we order a complete panel of blood count, comprehensive metabolic panel, coagulation studies, and all of that. And of course, I'll come to cardiac testing later on, but what these guidelines suggest is not to obtain diagnostic cardiac testing, that is either an esophageal or a transthoracic echocardiography or a cardiac stress testing in asymptomatic stable patients with known cardiac disease who are undergoing low to moderate risk non-cardiac surgeries, which is a big thing to see. And of course, there are a plethora of guidelines. This is one that comes recently in JAMA. And I think one of the best that I would like you all to follow through is the NICE guidelines that came in 2016. And they have again updated their advisories in 2018. Now, if you look at them, they have based their guidelines on two things. One is the ASA grade of the patient, right? The ASA physical status of the patient. And the two is the invasiveness of the surgery. So if you look at a minor surgery, where it means that it is a superficial surgery, excising a skin lesion, a draining an abscess, as was the case of a 20-year-old man, ASA 1, coming to us. What they suggest is that of the investigations, full blood count, coagulation profile, kidney function tests, including your creatinine and serum electrolytes, ECG, and lung functions or arterial blood gases for a minor surgery in ASA 1 and 2 are not needed at all. In patients who are ASA 3 and 4 and are undergoing minor surgery, we may consider getting a kidney function, especially a baseline creatinine level, maybe on patients who are at risk of acute kidney injury. And of course, if there is no ECG results available from the past 6 months, and of course, this goes for patients who are elderly, maybe above 65 years of age. So I just want to make it a little, I do not know how I would make it interactive on the Zoom session, but just to take you through a few case scenarios. This is a 45-year-old male scheduled for an inguinal hernia repair. Past medical history is notable only for obesity. His BMI is 30. He does construction work. He does walk very well. He can easily exceed 4 meds. His stop bang is just 2. There's no history of OSA or snoring. His physical exam is unremarkable except for his weight. His bedside spirometry was normal. So he wishes to undergo a laparoscopic hernia repair. Now, what would you order for this patient? Remember, what is the physical status of this patient? Can I have some feedback from one of you if possible, or otherwise I'll just move on. Okay, so though we might be tempted to, order a few tests here and there, at least a CBC up there, what we did see that this is an ASA2 patient, except for obesity that categorizes him as ASA2, which does not have any functional limitation. He does not actually need any tests. So this is what we all are aware of, the ASA physical status. So if I look at the type of surgery that we're looking at in this example is a repair of hernia. He wants a laparoscopic inguinal hernia repair. Now, if you look at, he's an ASA2, he does not need majority of the test, except if there are people who have symptoms of cardiovascular, renal, and diabetic comorbidities, or are elderly, then above 65 years of age, maybe a ECG might be needed. An AKI, risk of AKI may predispose this patient to need for baseline creatinine level or serum electrolyte. But for this patient in particular that we're talking about, basically we do not need any tests to go ahead. On the other hand, for an ASA 3 and 4 patient, if you look at it, they do recommend considering getting a full blood count for patients who have cardiovascular or renal disease. And if any symptoms of anemia, say breathlessness on exertion, have not been recently investigated and you find there is pallor on examination, so yes, definitely we'll get it done. Hemostasis is, we have to remember, this is something I really want you all to focus on, and I'll come to it again in the slides, is that we often ask for a PTI-INR, even if we were planning a spinal anesthesia. Now, we need to remember that it is to be considered only in patients either with chronic liver disease or patients who are on anticoagulants, which needs modification of their treatment regimen, or a clotting status needs to be tested before surgery using, and then of course we will use a point of care testing. So all of them have to be, specified and tailored to the needs of the patient and not as a generic order, blanket order to get it done. Renal function tests and ECG are of course recommended in ASA 3 and 4 patients, specifically because of the underlying comorbidities that shifted their ASA physical status to 3 and 4. Remember that. And consider seeking advice from a senior anesthetist as soon as possible after assessment for patients who are ASA 3 and 4 due to known or suspected respiratory disease. These are patients who might need a lung function or an arterial blood gas, as the case may be. We come to the major complex surgeries that are invading the basic major organ systems: total abdominal hysterectomies, endoscopic resection of prostate, total joint replacements, lung operations, colonic resections, radical neck dissections. If ASA 1 patient is undergoing a major surgery or a complex surgery, what might be considered is a renal function test and a full blood count, and of course ECG if the age of the patient is above 65 and there are no ECG available for the past 12 months and there's no newer symptoms that have developed. On the other hand, for an ASA 2 patients undergoing major complex surgery, the green is a total yes. Red, basically, it's a very easy tables to look at and understand. And so they do recommend getting for ASA 2 and 3 and 4 patients, getting kidney function and ECG to be done for these patients. The suggestions for coagulation testing and lung function testings are the same as they were there for intermediate risk surgery. So, you can perhaps have these kind of broad guideline to guide us to tailor-made and goal-direct our investigations for these patients. So coming back to the initial question which we started with, this 20-year-old ASA 1 scheduled for incision and drainage, I believe we do not need any tests. And if he were to undergo a hemicolectomy, remember he is ASA 1, and therefore for a major surgery and a young patient, it's just a CBC that would be needed for this patient. So coming to CBC, routine hematocrit is not indicated, as I said before, in ASA 1, 2 patients, but it is indicated only when there are history and signs of anemia. There's history of recent chemotherapy, history of chronic and or acute bleeding. There is history of liver, renal, and cardiac disease and has not been tested previously. Some of the guidelines do suggest testing for CBC and extremes of age. And of course, we all would agree for an anticipated surgical blood loss, we would like to have a baseline CBC coming to us. A chest X-ray is something that we do it quite often. And what has been found in various studies is that there are abnormalities, despite being frequent, they rarely influence management. So features to consider as per a confirmation of various guidelines are maybe active smoking, active heavy smoker, a recent upper respiratory tract infection, a chronic obstructive pulmonary disease in a patient who has acute exacerbations, cardiac disease, or any of these above, and a patient undergoing high-risk surgical procedure. We need to remember that extremes of age, an occasional smoker, a very stable COPD patient, or a cardiac disease patient who's stable, does not have any symptoms, or a resolved URTI, a patient coming to you after 4 to 6 weeks, are not to be considered as unequivocal indications for extra chest. At this point in juncture, I would also like to emphasize that we have also got into a habit of ordering chest X-rays for any post-COVID patient. We need to take a detailed history, understand what the magnitude of the disease that the patient had, and accordingly go ahead and order investigations. So this is basically a summary of what I talked before, coming from various organizations which talk about ordering a chest X-ray in patients who either have a COPD disease or an asthmatic disease, and of course patient is undergoing a major surgery, or there are acute cardiopulmonary findings on history and physical examinations. There is some recommendation of our ordering chest X-ray in patients older than 70 years who have chronic cardiopulmonary diseases. So this is something that we really need to consider and be very careful while ordering a chest X-ray. PFTs are to be only considered in patients where there is dyspnea of unexplained origin and you cannot explain it with your clinical examination. You are looking at a patient who has history of exacerbations and is now asymptomatic, but you would like to look at, is there some amount of reversibility, especially if the patient is undergoing a major complex surgery, say a one lung surgery. In patients who have scoliosis with restrictive function, and of course, as I said, we need to look at the invasiveness of the surgical procedures like lung resections, and therefore should not be used routinely to predict post-operative pulmonary complications. This needs a specific indication to go ahead. So this juncture, we'll take a break and we'll look at a small case. This is a 75-year-old male referred to a pre-anesthesia clinic for a decompressive evaluation for a decompressive laminectomy with pedicle screw fixation because the patient has worsening spinal canal stenosis and lower limb weakness coming in. He has history of his multiple comorbidities, his history of hypertension, stable angina pectoris, he's diabetic who is on insulin, he's an active smoker and a regular alcohol intake. This is something very common that you find up here north. But on physical exam, you do not find any evidence of chronic heart failure, no rhonchi, rales, Krebs, and he does not. He says he doesn't exert much and therefore does not give you any history of dyspnea on exertion. He hardly walks. He does not have a very specifically focused history or asked, and he does not give you any history of bleeding disorder or any bleeding otherwise. As I said, he hardly moves around his home with assistance and therefore has indeterminate meds. He did undergo a percutaneous intervention, had 2 stents up there, and he's on antiplatelets, ACE inhibitors, so all cardiac modifying and optimal drugs, bisoprolol, beta blockers, statins, and insulin. So he's on all of these. So what preoperative testing would you order? Do you want to order the whole lot that has gone blue suddenly? Maybe, yes. So this we really need to understand. What is the role of cardiac testing? When is it indicated? It is indicated for a non-emergent surgery with an elevated risk procedure and in patients who have suspected moderate to severe valvular heart disease or unstable cardiac conditions or patients with unknown or poor functional capacity with the condition that the testing will change management. And when I say change management, it means that either the surgery would be postponed or cancelled or a percutaneous intervention, coronary intervention would be needed for this patient. So that's very important for us to remember. And how do we risk stratify them? We look at the type of surgery, as I said before, and then we look at the clinical risk factors. We'll elicit the comorbidities and the severity of the comorbidities, look at the end organ damage, the progression, the functional limitation that this comorbidity has added on. In this particular patient, he has stents, so the type of stents, the timing of stents, and of course, how much of revascularization has occurred, the medical therapies. We need to go into detail into his history and examination and look at this history. And of course, we need to remember that in this particular case, it's a time-sensitive surgery. So you might be looking at an elective surgery, which could be perhaps postponed for a year. You could be looking at a time-sensitive surgery that needs to be done as early as possible, but you still have timelines in conjunction that you decide in conjunction with your surgical team. And of course, you will have urgent and emergent surgeries along with, right? And you need to look at the multivariate risk indices. And one of the most commonly used multivariate risk indices is the revised cardiac risk index, the RCRI criteria, which looks at symptoms of heart failure, ischemic heart disease, history of cerebrovascular accident or TI. We also look at the invasiveness of surgery. This risk index looks at intrathoracic, intra-abdominal, or suprainguinal vascular surgery, insulin-dependent diabetes mellitus, and creatinine more than. So in this particular patient, we are looking at actually 3 risk factors coming in. And how do we classify this patient based on this RCRI criteria? Is there is presence of 1 risk factor. The patient is categorized as low risk for major adverse cardiac events. Whereas if there are presence of more than 2 risk factors, the patient is categorized as elevated risk for major adverse cardiac events. Okay. And of course, we also try to determine the functional status of the patient, the functional capacity of the patient, and in this case, are indeterminate MITs. So what we are looking at is a patient who has an elevated risk of surgery, has to undergo a time-sensitive surgery, and has poor functional status. And as is often our case, we send them for clearances. And I think this is one word that should go out of our dictionary. We should be the one who should be deciding how to optimize and investigate and optimize this patient, and when to take up these kind of patients, in conjunction with, of course, a multidisciplinary team that involves your surgical team as well. So one of the informal investigations for cardiac testing employed is electrocardiography. So when are we going to look at ECG to be ordered for our patients? In patients who have signs and symptoms of cardiovascular disease, say presence of arrhythmia, structural cardiac diseases, or quite a significant respiratory disease. We're also looking at high-risk surgeries in patients. In these patients, especially with age more than 65 years and a presence of at least more than one RCRI clinical risk factors, we would order for electrocardiography. Whereas on the other hand, the patient is undergoing an intermediate or low risk surgery with no or less than one RCRI clinical risk factors, we should not be ordering for an ECG. If you look at the AHA-ACC guidelines, which recommend preoperative resting 12-lead ECG, they recommend it for, as I said before, for known coronary heart disease, significant arrhythmias, peripheral arterial disease, cerebrovascular disease, or significant structural heart disease. And you may consider, but for low risk surgeries or moderate risk surgeries, we may perhaps not undergo this procedure. Resting echocardiography, something that really boggles our mind, and we look at our cardiologist to recommend it. Remember that we should never routinely offer resting echocardiography before surgery. We need to consider if the patient has a structural, say, heart murmur or a cardiac symptom, say breathlessness or syncope or chest pain, or signs and symptoms of heart failure. It is only in very few of these conditions that a resting echocardiograph might be useful. It will not tell you the exact situation in a patient who does not have these, but you're trying to find out how would my patient perform under anesthesia. So in this particular patient, or for patients coming for TKRs who hardly walk and have multiple comorbidities, would you like to go for a stress echocardiography? So what do our guidelines say? They say it is reasonable for patients who are at elevated risk for non-cardiac surgery. So there has to be an elevated risk, meaning thereby there are more than 2 clinical risk predictors in the RCRI category, have poor functional capacity, that is the METs are less than 4. And so they may be advised to undergo pharmacological testing if it will change management. So routine testing is again not recommended, especially in low risk. And some of the guidelines, they also recommend even for moderate risk surgery or intermediate risk surgery, they do not recommend for asymptomatic patients. Some of us would love to order BNP as a further guide to to settle our own fears, but we need to remember that there is no role in the preoperative period, though European Society does suggest use of it in high-risk patients undergoing major surgeries, say major vascular surgeries. If I looked at this, editorial, what they found is that all this testing, especially echocardiography, stress echocardiography, does impose a potential financial burden and has a low value in testing, and especially in patients who are you have to be very focused, and you need to know that this testing can really change the management of the patient, and of course has a major consideration towards reducing the MACE during the perioperative period. So moving on to other tests like testing for glucose, there are no good evidence for and against, but if there is clinical suspicion for disturbances in glucose metabolism, say vascular surgery, spine surgery, orthopedic trauma, where you already might have an hyperglycemia up there, you might get to it. HbA1c is something that is recommended only if there are no testing done for the diabetic patient or in the preceding 3 months, or the patient reports poor control on home testing. Though we know that a value more than 9% merits postponement of an elective surgery, we need to really monitor these patients carefully because these are indeed predictors for postoperative hyperglycemia and cardiac morbidity. RFTs, especially electrolytes and creatinine, are, as we said before, are indicated once there is presence of, say, diabetic, especially uncontrolled, hypertensive, long-standing with arteriosclerosis, chronic heart failure, coronary heart disease, chronic kidney diseases, liver diseases, and certain medications like diuretics, ACE inhibitors, digoxins, and theophylline, etc. But we need to remember that an eGFR is a superior test to serum creatinine because it is not influenced by confounding factors like mass, gender, and age. And there is a new kid in the block, plasma cystatin C and neutrophil gelatinase, of course, not available in most of our centers, which have been suggested as new biomarkers for renal functional or tubular damage. They're still under research and would need specific indications to be done. A very common test, preoperative urine analysis. They look at the guidelines. They do not recommend a routine pre-anesthesia urine analysis, except if the patient is undergoing a prosthesis implantation or a urologic procedure in the presence of, and there is a presence of symptoms of urinary tract infection. So in this, it will be a case-to-case decision to do it. A very pertinent question, and I think I've been trying to change this tradition even in our setups, is to do routine coagulation screening for patients who are scheduled to undergo any type of regional anesthesia. Now, this is not recommended as per guidelines. Coagulation studies are reserved for patients who have history and physical findings that suggest that there are bleeding and coagulation problems. There is an underlying liver disease which is significant enough to cause a bleeding disorder, or a known bleeding disorder or previous bleeding complications is on current anticoagulation. So this is very, very important to remember that testing has to be reserved only for these particular group of patients. So to summarize all that I said till now, routine preoperative tests are not recommended. Selective preoperative tests can be considered in specific comorbidities. So therefore, ECG, CBC, X-ray chest, coagulation, urine analysis, and timing is all that we talked about has to be tailored to a specific underlying comorbidity that is elucidated on a detailed history and physical exam. There's still a question lurking on our minds, which can be explained through this scenario. A 25-year-old female who is married, has been actively trying to get pregnant, is a basketball player, but however, she lands up in your ER with a torn left ACL, and the surgeon wants to fix it. She's in excellent health. She has no prior surgery, no medications, but irregular menstrual periods. And she feels that are secondary to her level of physical activities, but she is quite certain that there is no possibility of pregnancy, and a physical exam is. Would you offer a pregnancy testing to her? That's the question. Otherwise, an ASA1 patient does not need testing. So if you look at the literature, it is still inadequate to inform patients or physicians on whether we should be offering the test. But if I look at this particular statement on whether anesthesia causes harmful effects on early pregnancy, it has been proved beyond doubt that anesthesia per se, the anesthetic agents per se, of course, do not harm. It is the conduct of anesthesia, the way we do it, perhaps may lead to some kind of either early labor coming in or natal death. So if you look at the guidelines, pregnancy testing may be offered to female patients of childbearing age and for whom the result would alter the patient management. Also should be offered to patients who have irregular bleedings, who have irregular menstrual cycles, whose histories are uncertain, right? So therefore, we really need to look at it and of course, inform the patient and educate her and then take her into confidence before you offer her a pregnancy testing. Elderly patients are one group of patients where we are always scared because we think there is always a lurking comorbidity. So how would you actually proceed with offering a test in an elderly patient for an elective cataract surgery? I would rather select the patient test as per the patient's condition. But recently, there has been this review article that has come in 2021 in the current opinion and anesthesiology review up there, which looks at preoperative testing. And what they have indeed recommended is a whole panel of tests to actually predict postoperative outcomes. But what we really need to remember is that a thorough preoperative assessment of frailty, cognitive impairment, polypharmacy, nutrition, and limited capacity, something that's very common in this age group, geriatric age group, which is to be assessed with a multidisciplinary geriatric specialist, is what should help us to guide testing and not a blanket whole big gamut of testing. So in the end, I would recommend that we make institutional protocols based on evidence-based guidelines. And we are very happy, and I have Dr. Balabhaskar there, and would love to have his comments as we are preparing to come up with the guidelines on preoperative testing. But I believe the biggest challenge would start after that. The biggest challenge is how to get these guidelines implemented into clinical practice and to be accepted by the teams, both surgical as well as anesthesia. And in this process, this is one of the very good articles that looks at how to actually put in this process in place. So what these group of authors did was that they looked at the root cause of non-acceptance of these guidelines into a clinical practice. They looked at the process, the way the patients are being evaluated and tested across in their particular area. And then they plan to do something called a plan, do, study, act cycles, a quality cycle there up there. And what they're basically, when they did a study, their chart baseline data revealed that 91% of patients had no indications for coagulation testing. 41 did not have any indication for electrolytes and renal profile, 35% for an EKG. So what they did was, based on their particular local resources and the available guidelines, they made a grid, and they offered this grid to the PAC clinic and also to their physicians and surgeons. And on the basis of this, once they implemented this grid for their based on the guidelines, they did a post-implementation review, and what they found that unnecessary coagulation profiles, electrolytes, and EKGs were reduced by a whopping 81% to 68%. So that's what is needed across our own clinical areas. So my take-home points are that routine tests, that is tests done without any indication, are actually a waste of resources. As I said before, and on risking repetition, it should be based on a rigorous history targeted physical exam, a perioperative risk assessment, and risk-benefit assessment, asking those 5 questions in clinical judgment. Needs to be goal-directed, as I said, and has to have a significance to change or modify treatment. And repeat testing, mind you, is not indicated. And you can have these guidelines maybe 6 months to 1 year or 3 months, but it's very important to see that during that period, there has been no change in the clinical condition of the patient. So with these take-home points, I thank you all and would love to have questions. Thank you so much. I think I went a little overboard.
Anita, you're muted.
Anita, your voice is not
Muted.
you are muted.
Sorry. Thank you very much. Thank you very much, Dr. Anju, madam. And really, we are doing a lots of unnecessary testing. And but what to do? We are so afraid that our Indian patients might not share with us. They might lie to us, or there are various other aspects to it. I'm sure we will discuss all this. But Dr. Manisha, we are going to go ahead with all the lectures, and then we will take up the questions. That is the plan. Yes. So I request, I thank Dr. Anju madam for this exhaustive but yet very concise, in a beautiful way. She told us what is evidence-based medicine about the important topic of investigations. And Dr. Balabhaskar is with us. We are very lucky to have him. And he is doing a lot of research, and shortly we'll come out with our own Indian guidelines. So I request Dr. Balabhaskar sir to share his thoughts on this important subject.
Thanks a lot, Dr. Anita.
Dr. Balabhaskar sir.
Yeah, thanks a lot, madam. Thanks. And I must compliment and thank also Dr. Anju in the sense that he has reflected many of the concerns which I faced as a part of the group which is preparing the guidelines on behalf of ISA National. And as our colleagues were telling, there will be a lot of discussion related to the preoperative investigations once we open up, because it is the one which affects us in our day-to-day practice, not just as in medical colleges or big hospitals, but also in private practice. So what I would like to do is briefly give you some background of what has been done as part of our guidelines on behalf of the ISA. I've got a draft here which I would like to project now. Just to see that our people also get used to the way guidelines are also framed. So our expectations are always heavy. We talk about individual case-to-case basis and expect that there will be guidelines on the management of an individual case. But it is definitely not possible, mainly because guidelines are formulated based on evidences. And when evidences are there, definitely we are going to talk about it in strong words for the benefit of the members. And if they are not, we are not able to, and we are not like legally allowed to give recommendations with respect to that. So I will give you a primer and introduction of what has been going on. Our work is almost 90% done. Only thing is we got inputs from our colleagues as part of an online survey, which we conducted about 2 weeks ago. Almost 1,200 of our colleagues have responded. And also we had a small poll during a session during ISACON 2021 at Ahmedabad, where we talked about the pre-operative investigations also. So we included questions where we never had good quality evidence. And we thought we should be taking input because our guidelines are mainly India specific. Because we have got different levels of facilities of healthcare, cost considerations are very important. And of course, ethics and medico-legal considerations have become very important in the last, all of us know, the Consumer Protection Act and other things. We are at the receiving end. And as is common, we cannot comment upon patients who belong to ASA 3 and more in general, because there is complications related to the pathological process and the type of surgery also, and the risk of anesthesia. So whatever guidelines have been now drafted are addressed towards ASA 1 and 2 patients, and they are addressed towards elective, minor, intermediate, and major surgeries. So it is not possible to comment upon emergency procedures, mainly because a lot of confounders will come into play and will not be able to go into those steps, and definitely it cannot be part of any guideline. And it's a saving grace, it's a double-edged weapon when we say that there is a discretion for the attending anesthesiologist. Because guidelines are only guidelines, they cannot be made mandatory. But if an attending anesthesiologist, based upon his knowledge and experience, he is able to decide, yes, something is necessary and something is not necessary, that definitely that can also be accepted by the court of law. And secondly, there is evidence-based medicine jargon. So some of our colleagues, when I was discussing, they said, no, you should be telling like that and you should be giving an opinion like this. But unfortunately, we are not, and we should not be giving such statements. So when I say recommended in terms of the guidelines, I should be having strong evidences. And when I say strong evidences, it should be in the form of meta-analysis, systematic reviews, and those should include basically randomized controlled trials as much as possible. So if it is so, for and against ordering investigations, we have got recommendation. For example, I can strongly say hemoglobin is not indicated, and I can strongly say that hemoglobin is recommended and not recommended. That's the way it is. And there can also be weak evidences where we don't have meta-analysis and systematic reviews and randomized controlled trials, or trials in terms of strong numbers also. There are many other criteria. If they are not there, we cannot even phrase it as recommend, word it as recommended. We have to only say it as suggested. And this suggestion is also for ordering an investigation, and that suggestion is also for not ordering an investigation. So that's the way the guidelines are also formulated. So slightly going into next step, if there is a high level of evidence and more than one moderate level of evidence, we call it as recommended, which is a strong statement. And the level of evidence is very low and low level of evidence, we call it as weak, and the statement would be only in the form of a suggestion. So as Dr. Anju had clearly explained in the initial part of the introduction, what is important in terms of ordering preoperative investigation is normally surgical, and the factors which should come to our mind are the surgical factors and anesthetic management. So in fact, all of us know majority of the investigations are pre-ordered by the surgeon or the admitting physician. And our aim, of course, should be to see whether there is something on some effect on the surgical outcomes and anesthetic outcomes. Okay, so all of us we say, so the patient has not had this investigation, this should be done. So the simple basis must be whether this is going to change the surgical approach, this is going to change the anesthetic management, this is going to improve or affect the outcome of the surgery and anesthesia. So these are the important things which we must be first bothering about. And last one, deliberately put, is confirm an abnormality suspected from history or physical examination. So this is the basis of ordering the preoperative investigation. So what if we keep on ordering unnecessarily? So they are the ones which are not indicated. So they are not going to affect the management and outcomes for the patient. And definitely waste of money, especially if you are talking about a private or freelance practitioner and even a bigger setup like corporate setup. Are we justified, even in the presence of insurance, are we justified in advising an investigation, and is it an economic consideration? And sometimes what will happen, many of our the patients and attenders are all internet savvy, Google savvy. So they go through the internet and they become anxious. Patients become anxious, the patient attenders will become anxious, and they will keep on pestering us with new questions also. And it is possible that some of us as physicians or whatever may undertake an inappropriate treatment based upon this investigation, an investigation which is abnormal, unusually, and we don't have basis also, and you may be chasing further investigation also. So thus, these are the limitations, and of course, the questions of ethics also come. So we should not be swayed by some of the investigations to be done on the advice of some other colleague, and because even the patient is demanding. I'll give you in brief what are the possible draft outcomes of our ISA guidelines. Very simple, as was displayed with respect to the NICE recommendations by Dr. Anju. The CBC and FBC, generally they are not advised for patients undergoing minor and intermediate risk surgeries. So it is recommended for patients undergoing high risk surgery only. But an example was given like incision and drainage of breast abscess. So it's very simple to understand that if it is ASA 1 and 2 patients, an elective procedure, we may not need it. But at the same time, the patient has got a severe infection which leading on to even sepsis. Or if the patient is already having a significant, it's a known case of diabetes mellitus where there's risk of infection. So those are the conditions. Even if the surgery is taken as minor, we may be forced to advise a CBC for the patient. Similarly, broadly speaking, LFTs are not advised for minor to intermediate surgeries, and only for high-risk surgeries we can suggest. So not to say if it is directly a hepatic procedure that we should not be doing. So these are left to the discretion of the anesthesiologist and the surgeon, and of course the other physicians. Serum creatinine again is not recommended for patients undergoing minor to intermediate surgery, and it is recommended for patients undergoing high-risk surgery. Okay, this is again why I am trying to repeat all this is, when it comes to discussion, there is always a difference of opinion from within our colleagues also, that why I should not be ordering and why I should not order a CPC which includes everything. Electrolytes not recommended for patients undergoing minor, intermediate and high-risk surgery. So that said, for example, we also had discussion with Dr. Anju and Dr. Divatia, who are also part of our expert team for ISA national guidelines. A patient who is posted for TURP, okay, who is already going to undergo a TURP procedure, maybe that's a patient which fits into an intermediate criteria. We must be advising normally about electrolytes. So there are exceptions for all the guidelines, and we can also decide on a case-by-case basis. And coagulation profile, we just heard about coagulation profile also. We have recommendations and data mainly related to the APTT and PTAN. We don't have any strong evidences for other things. And even for minor, intermediate and high-risk surgery, generally APTT is not recommended. This is based upon the available evidences. And in fact, PTANR is not suggested, means there is very weak evidence to suggest that we can advise PTANR for minor, intermediate and high-risk surgeries. Okay, so if what I have told here is not recommended, it's a strong statement against using APTT. Not suggested is a weak statement. okay, I can use the discretion, I can still advise. Blood sugar, not recommended in all the age groups for minor, intermediate, and major surgeries. ECG is not suggested for patients undergoing minor to intermediate risk surgery. I am not talking about a pre-existing cardiac patient, and definitely we will be talking about ASA 3 and more, and you have got set guidelines for management of cardiac patients as per the various international bodies. Chest X-ray, it had been a routine till about 20 years ago. It was very frequently we used to advise chest X-ray, and even the evidences currently say it's not suggested for patients undergoing minor to intermediate surgery. And clarity was given by Dr. Anjo in terms of possible scenarios where we can decide on chest X-ray. And is there an age criteria? Again, it is controversial. We don't have clear-cut age criteria. And I got some data from our 1200 survey, which I will be probably summarizing and taking up into consideration in the next 15 to 20 days as part of final drafting of the guidelines. Age-based testing. Okay. Should I be advising an ECG beyond 40 years of age, 45 years of age? Again, the statement is without specific coexisting disease, a positive history or findings on physical examination, there is no relationship to age in terms of advising the investigations such as hemoglobin, serum electrolytes, radiographs, and even the pulmonary function tests. Time validity. Yes, this was also touched upon by Dr. Anjo. It's like it's common in our practice. So somebody would have been advised and undergone investigation about 3 months ago. CBC would have been done, RPS would have been done, creatinine would have been done. So he comes for a procedure. Should we be repeating the similar investigations? So our team also went into the evidences, collected all the details. We found that results from laboratory tests within 6 months of surgery can be accepted unless major abnormalities are present or patient's condition has changed within 6 months. Similarly, with respect to ECG, no new ECG is needed if results from an ECG within 6 months of surgery are normal and the patient's condition has not changed. So these are some of the draft points. And time validity, if you talk about other investigations, about CBC, RFT, LFT, coagulation profile, up to 2 months before the scheduled surgery, it's not suggested to repeat chest X-ray ECG done up to 12 months before the scheduled surgery, provided underlying condition of patients has not changed in the intervening period. So this is the previous one is the one which I have compared with the ASA task force. So this talks about 6 months, both for routine investigations and for ECG. But our guidelines are more likely to talk about 2 months for CPC, RFT, LFT, and coagulation profile, and 12 months for ECG and chest X-ray, provided the patient's condition has remained stable in the intervening period. So these are the ones which are likely to be taken up. And I can come back later on once Dr. Divatia has completed his presentation, where we will have further discussion about the first topic also, because I found some questions are there in the chat box. Dr. Anjo can respond and I can also join in later. And time permitting, I will present about 4 to 5 slides about our perioperative fasting and feeding guideline, just to highlight the efforts of the ISA National so that we share our experience also. Thank you very much.
Thank you, sir. Yes, Samir. Samir? Hello? Hello, Samir is there? Hello?
So we'll continue with.
Hello?
Avinash,
Avinash sir,
you can continue.
You can continue.
Okay, thank you, sir. Now, I request Dr. Divatia sir to start with his presentation.
Yeah, good evening. And thank you very much for having me here and speak on this very important but difficult topic on preoperative cardiorespiratory optimization. We've talked a lot about investigations, but at the end of the day, the whole idea of our pre-op checkup and including our history and investigations and so on is to get the patient in optimum condition for surgery and the post-operative period. right? And in many patients, there can be some risk factors, and we all know what those sort of risk factors are. But essentially, some of them are not modifiable, right? So, for example, you can't modify age or the sex or the the diseases, the genetic sort of predisposition the patient may have. There are acquired diseases which are modifiable, like anemia, COPD, and diabetes, and so on, which of course we will aim to sort of correct. And there are also lifestyle changes which can be made, which can help in the perioperative period, like cessation of alcohol or smoking or something like that. So when we're talking about optimization of the patient's condition, although we don't realize it, we probably are actually looking at collaborative shared decision making. That's, for example, if the patient says, I'm too old, I'm too sick, I don't feel like getting operated, and the surgery is not going to happen, right? Then you're going to try and modify whatever you can with medical treatment. And there might also be necessity for a behavioral change, which which sometimes is required to handle these sort of things. So the preoperative optimization is not just a question of give little bronchodilator, give little antibiotic, give little digitalis, or give little diuretic, but it may encompass a whole lot of other interventions, which will include behavioral change and so on and so forth. Okay. Now, before I go on specifically into cardiac and pulmonary sort of thing, there is a very broad concept which is now making the rounds, and which is called prehabilitation. And this applies especially to patients with cardiovascular and respiratory morbidities, but also to elderly and weak patients, and especially in cancer patients. A lot of work has happened in cancer patients on this concept of prehabilitation. So this is a means of preparing the patient physically and mentally for their operation and for the subsequent post-operative treatment. For example, and the ability to return to a physically and psychologically healthy state as soon as possible. So we've all heard of ERAS, right? That's early recovery after surgery, or enhanced recovery after surgery. But this goes a little beyond that, because we want, especially in cancer surgery, you want patients to be fit to receive chemotherapy or radiotherapy, and what we call as return to intended oncological therapy. So the prehabilitation or the preparation for surgery must start before the surgery takes place, and even before before the surgery, so that the patient is fit not only for the surgical stress, but also to make a faster recovery in the next few weeks, so that he can be back to his normal functioning, and he can also start in a fit condition to receive chemotherapy, for example, for cancer, right? And it has an important role in recovery by diminishing the risk of post-op complications. And the whole idea of trying to fix the comorbidities and to prepare the patient and to optimize the patient is to minimize post-op complications. Because we know that one of the major drivers of post-operative complications are the patient's comorbidities and the patient's condition. A few problems do occur because of some things that may happen during surgery and some post-operative complications in the post-op period. But by and large, a lot of problems, a lot of complications are related to the inherent comorbidities that the patient may have. And prehabilitation has a sort of multimodal sort of approach. And one of the very important things which is very much neglected but which is coming up is exercise and physical activity. And patients undergoing major surgery are encouraged to undertake a schedule of exercise, which is prescribed, and so that they have some sort of physical activity, aerobic exercise, as well as a little bit of strength training. I'm not saying they're going to lift 100 pounds and that sort of thing, but a little, even if they've got mild heart disease or something, they should walk to the extent that they can and do a little bit of weight training, a little bit of resistance training, so that their muscles are in optimum condition. Of course, you're going to optimize nutrition and also psychological well-being. So all these things are part of a multimodal approach to rehabilitation, and the aim is to make the patient recover both physically and mentally to go forth into the post-op period without any complications. One of the things which has helped us objectively to decide what is the physiological reserve of the patient and whether our interventions are improving the patient's physiological reserve is cardiopulmonary exercise testing, which is there in a few institutes. It's not a very well-known thing, but some gyms may have it. So if there are a few high-end gyms which may offer cardiopulmonary exercise testing, because they do it for athletes and they do it for training in athletics and so on. But for us, we can use it to detect both cardiovascular as well as respiratory problems. The key concept is that as you exercise, the oxygen consumption increases, and persons who can increase their oxygen consumption to match the level of exercise do well, and those who cannot reach a certain level of oxygen consumption will not be able to exercise and they will not do well, right? So cardiopulmonary exercise testing is an integrated global assessment of the cardiopulmonary and the hematological system, because even anemia is required to deliver, so hemoglobin is required to deliver oxygen to the tissues. So anemia also comes in the picture. It is dynamic, it assesses the organ function at rest and under stress, and therefore indicates a physiological reserve, and you can find out undiagnosed things. And the rationale for doing this pre-op is, we know that during exercise, we have to increase oxygen supply to our muscles and to the body, and the cardiac output has to increase, and the ventilation must be, and cardiac output must be matched to allow us to perform that exercise. And the same sort of logic applies to surgeries, that we know that after major surgery, the oxygen consumption increases, an increase in metabolic rate, metabolic consumption. And if patients are able to increase their oxygen delivery as well as the oxygen consumption to match the increased metabolic needs after major surgery, then they will do well. And so we assume that if the patient can exercise well, he will also be able to tolerate the surgical stress well. Or if he doesn't meet the requirements during exercise, he may not be able to meet the requirements after major surgery. So that is sort of rough assumption that we do when we equate physiological exercise to surgical stress. And so we get an objective assessment, we get a numbers, right? We'll talk about some of the numbers, but we told you about oxygen consumption, the VO2 max. You get an objective assessment of the functional exercise capacity. Okay, you can make out whether it's cardiac or respiratory in origin, and you can therefore risk stratify sort of patients. And this prehabilitation becomes objective. So you do baseline CPET, see what is the oxygen max, VO2 max, put them through a regime of exercise and fitness and nutrition and all that thing, and then you measure it afterwards, and you know whether there's been some improvement or not. There's another concept which is now coming in, and which I would again like to introduce, is a concept of frailty. Now, it is well known in geriatric medicine. So when you're anesthetizing elderly patients, or when you're talking to elderly patients about elderly patients, then this concept of frailty is there, but it also applies to other patients who have chronic illness, who have chronic disease, who have cancer. And essentially, it is syndrome of decreased physiological reserve and resistance to stressors. Stressors means one stressor would be surgery, for example, which leaves the patient more vulnerable to poor health outcomes. And these patients tend to have falls, they tend to have restricted mobility, they have more hospitalizations, and the multidimensional construct that includes deficits related to physical performance, nutritional status, mental health, and cognition. So these are some of the important things which you need to take into account. Okay, so again, like I said, it takes into account the physical performance, cognition, malnutrition, and mental health. And how do you recognize someone who's frail? There are different scales. We won't go into all of them, but there is one simple way of screening for frailty. And this is from the United States National National Surgical Quality Program. And one is shrinkage, right? So they have a weight loss of more than 10 pounds in the last 1 year. Weakness in the form of decreased grip strength. Exhaustion, so they report that they feel tired and they are not able to work or walk as much as they used to. There is a low level of physical activity and they walk very slowly. So these are very simple things, and if they have 4 or more of these issues, then we say that these people are frail, right? Now, I think the simplest sort of colloquial term for frail would be khakadu. If you say a patient khakadu hai, you already think of someone whose outcomes are going to be worse. And this is a sort of objective way of saying that this patient is frail. So you look at weight loss, weakness, exhaustion, low physical activity, and slowness in walking. And frailty is associated with worse outcomes, both in terms of mortality and in terms of hospital stay and consumption of resources. Okay. And these patients also need optimization. Now, you may say a khakadu patient, you cannot make him a wrestler, but you can improve his nutrition, and you can improve his cognition, and you can make him do a little bit of exercise, whatever is tolerated, to improve his exercise prehabilitation. So prehabilitation is a very important component even in frail patients. So we need to keep these aspects in mind as a sort of whole care of the patient as a whole, especially of the high-risk patient, and especially of patients who are frail and patients who are likely to suffer post-operative complications, not just physical complications, but also cognitive dysfunction and cognitive decline. Okay, so how do you optimize someone who's got a respiratory problem? And this is one bold statement which I've read. I'm not sure I agree with it 100%, but there is some truth in this. Just the fact that someone has a respiratory condition, say like COPD, or the fact that person is a heavy smoker, does not necessarily make them prone to complications. What does increase the risk of complications is if their lungs condition is not good. In other words, if they're hypoxic, if they're not hypoxic, the saturations are lower than predicted. If maybe their lung function is worse than predicted, right? And the presence of recent infection. So these are two important things which are going to decide on what is going to create complications. And we have to try, obviously, to take care of these sorts of things. And we can also quantify the risk objectively in a cardiopulmonary exercise testing. And a person who's at low risk has a VO2 max, so maximum oxygen consumption capacity of more than 20 mils per kilo, and what is called an anaerobic threshold. I don't have time to go into the details of a CPET, but anaerobic threshold is a time when the CO2 production exceeds oxygen consumption, and that's the time sort of when anaerobic metabolism starts taking place, and the oxygen delivery is not adequate for the needs of the tissues, right? So if you've got a high anaerobic threshold, means you can work out for a long time before your anaerobic metabolism starts, you're at low risk. Moderate risk is a VO2 max of 10 to 20, and anaerobic threshold of 10 to 12. And a high risk is someone who's got a VO2 max of less than 10 mils per kilo and a anaerobic threshold of less than 10 mils per kilo. What do you do when you identify a patient with a respiratory problem? So smoking cessation is extremely important. Should give bronchodilators, especially if the patient has a reactive airway disease. Make sure he can cough and loosen secretions, removal of secretions by physiotherapy and so on. And respiratory exercise is extremely important. Now, we all know of incentive spirometry, right? So that's one very important exercise which needs to be done. Right? What about smoking cessation? Now, people argue that if we stop smoking, then maybe for some time the airways are a little more reactive. And anyway, it takes 6 weeks, 12 weeks for the ciliary action to return to normal. So is it really worth making a heavy smoker stop? Because then there are issues of withdrawal and autonomic dysfunction and so on. But even with, we all know that even with smoking cessation for as short as 12 to 48 hours, the carbon monoxide levels come down and the effects of nicotine on the nervous system and the body reduce. So, and after 1 week, the airway reactivity starts reducing significantly. So if you have time and you've got the patient's cooperation, a long period of smoking cessation is fantastic, but even 1 day smoking cessation is important and can give you a good outcome. And bronchodilators, apart from reducing causing bronchodilation, they reduce the air trapped in the lung and therefore reduce hyperinflation, which improves respiratory muscle function, right? And because the airways are dilated, the increased mucociliary clearance, reduced cholinergic transmission, easier for the patient to cough. So apart from relieving the bronchospasm, the bronchodilators have multiple other benefits, and patients should be given bronchodilators to improve their respiratory condition. Of course, you need to control infection. We said that infection is a major contributor to post-operative complications. So hydration is important. Some patients may need oxygen supplementation or CPAP if they've got sleep apnea and so on. And of course, selected patients will need steroids, and those who've got Cardopulmonary or those kind of things will need diuretics and diuretics. Inspiratory muscle training, apart from spirometry, incentive spirometry, there is, you can, just like you do muscle exercise for the whole body, you can do inspiratory muscle exercise to increase inspiratory muscle strength and endurance. And you can have a sort of circuit device which sort of stresses the respiratory muscles, makes the patient breathe harder, so to increase the maximum inspiratory strength. And again, this can be done in a sort of supervised and graded fashion prior to surgery. What about cardiovascular disease? Now, this is a this is opening a Pandora's box. Dr. Anju has spoken extensively about ischemic heart disease and risk stratification, and what tests you will do. The commonest sort of disease that we come across is hypertension. And I think in all cardiovascular disease, the question that is often asked is, what drug should we continue and which drug should we stop and how long should we continue them and so on. And one of the drugs is beta blockers. Right? So as far as beta blockers is concerned, I think there is very good evidence that if patient has been on beta blockers, they must be continued throughout the perioperative period. Right? If the patient has been on beta, should not discontinue beta blockers abruptly because that is harmful. Antihypertensive medication.
Okay,
should be...
I found this on the web. For patient has been on beta blockers, you should not discontinue beta blockers broccoli because that is harmful. Check it out.
Okay, that was Siri that got activated by pressing some button. Okay, all medication should continue. All other antihypertensives should continue, with the exception perhaps of ACE inhibitors and angiotensin receptor blockers, because they tend to cause hypotension, and you could sort of stop them for 24 hours before and after surgery. But the recommendations are varied in different sort of things. When should you postpone a hypertensive patient? By and large, not. Unless the systolic is more than 180 and diastolic is more than 110. But again, it depends, right? So, but otherwise, as far as beta block, antihypertensive medications concerned, it should all be continued. Beta blockers is a bit controversial, and the recommendations have changed over the last 10 to 20 years. And now I think almost, this is a European guideline, this is the American guideline. They both agree that patients receiving beta blockers before surgery chronically should continue beta blockers. That's a class 1 recommendation. Should you start beta blockers for cardiovascular disease, that's hypertension or ischemic heart disease, because this patient is about to undergo major surgery? So should the beta blockers be started to optimize the patient's condition just prior to surgery? And the Europeans are a little more charitable. They say if they've got a risk index, a number of clinical risk factors in the revised cardiac risk index of 2 or more, it is reasonable. You could consider starting beta blockers, or if they have known ischemic heart disease, right? But these must be titrated, right? So they should not be given without titration. In other words, if the surgery is tomorrow, I can't start the beta blockers tonight because that time doesn't give me time to titrate. I should be able to titrate to blood pressure, make sure there's no hypotension, heart rate's not falling too low, and those kinds of things. The AHA guidelines actually say that you could begin in someone who's got 3 or more risk factors, high risk surgery, and long enough in advance to assess safety and tolerability more than 1 day prior to surgery, right? So that, again, the same thing. So you should not start beta blockers immediately pre-op, but you could start it in high risk patients if you've got a few days to sort of titrate and make sure you've got the right dose of beta blocker, because you had the POISE study which was done comparing metoprolol extended release versus placebo, and to their surprise they found a 30-day risk of major adverse cardiac events was higher in those who got beta blockers because they had excessive hypotension when they got beta blockers. So they had reduced myocardial ischemia, but they had more stroke because of the hypotension that was produced by beta blockers. So you need to make sure the patient's hemodynamics and everything are well maintained throughout the period. They are on beta blockers and titrate them. What about statins? Again, if they are on statins, continue. You could start statins freshly in patients, provided if they are undergoing vascular surgery. Otherwise, there's no real benefit, right? But some people might say if they're undergoing very high risk procedures, then maybe you could start with clinical risk factors who are undergoing high risk procedures. So you could start, but by and large, there is no specific need to start statins. What about drugs like aspirin and clonidine? Now, this was a POISE 2 study, a large study, and they found that aspirin and clonidine had no effect on the rate of death or non-fatal MI, but aspirin increased bleeding. But remember, these are in not in stented patients, but only at risk for vascular patients, only at risk for vascular complications, right? So many of them could be primary prevention with aspirin. So maybe it's not really absolutely necessary to give aspirin in such sort of patients, right? So, I got a high risk patient who's not on aspirin. and he's never had a myocardial infarct, he's never had a stent. Should I start him on aspirin just because he's undergoing major surgery? Probably not. Patient with ischemic heart disease, should he undergo, and he's undergoing a major surgery, let's say he's undergoing a Whipple's or this thing, then should you actually give him, take him up for a coronary angio and a stent if required? So again, the recommendation of almost all societies are quite clear, is that revascularization before non-cardiac surgery is recommended only when indicated by the clinical condition of the patient. So if he needs angiogram, coronary stent for cardiovascular, cardiac symptoms, then you should go ahead and do it. So it's not recommended just because he's supposed to undergo major surgery and he's got ischemic heart disease. Now, I think increasingly, more and more, we are seeing patients who come with a coronary stent. Right? Patients have had a coronary stent either because they had an infarct or because they've had stable ischemic heart disease. So in either case, they have a stent, and that is a tricky situation because after a coronary intervention, after a stent, the stenotic lesion is transformed to unstable area because of a rupture of his endothelium. And until this is covered, this is regenerated, non-cardiac surgery is risky because that part is prone to developing a thrombus. Right? And if the stent, if there is in-stent thrombosis, there are 30% risk of myocardial infarction with a very high mortality. And therefore, in order to prevent in-stent thrombosis, all patients with intracoronary stents after the procedure, the stent procedure, are put on dual antiplatelet therapy. Usually aspirin and clopidogrel, but increasingly patients are now being put on other drugs such as prasugrel and ticagrelor. Okay. So if this patient with a stent, before that vessel has got back its lining, before the endothelialization, this patient is that area is unstable, and in the presence of surgery, if you've stopped aspirin and you've stopped clopidogrel, there is inflammation and a prothrombotic state because of the surgical procedure as a response to surgery, increased platelet adhesiveness, right? And that sort of causes more higher risk of platelet aggregation and thrombus formation inside the stent, and that can lead to stent thrombosis, myocardial infarction, and death. And the post-op myocardial infarction rate is 35%, and a 5 to 10-fold increase in perioperative cardiac deaths in patients with intracoronary stents. So we have to be careful in patients with intracoronary stents. On one hand, they need the dual antiplatelet therapy to prevent in-stent thrombosis, right? But at the same time, they're likely to bleed because of the dual antiplatelet therapy. So there's a possibility of increase in surgical blood loss if you continue the therapy. But if you stop the dual antiplatelet therapy, there could be an increase in platelet adhesiveness and increase in stent thrombosis and myocardial infarction. So what do we do in such patients? And that depends on the type of stent. Now, in the past, we had angioplasty without a stent, we had bare metal stent, and then we had drug-eluting stents. Now, the older drug-eluting stents, the first generation drug-eluting stents actually required dual antiplatelet therapy for almost a year. But the current generation, the newer ones, require only for about 6 months. So if the patient, on the other hand, have a bare metal stent, right, they need dual antiplatelet therapy for only a month. So don't stop. So don't stop for elective surgery. Again, we are talking about elective surgery. Don't stop dual antiplatelet therapy for 1 month at least in patients who are dual antiplatelet therapy. And after 30 days, you can go ahead. If you've got a drug-eluting stent, the modern drug-eluting stents, then at least 3 months must pass. Right? Don't wait. This is the AHA recommendation. At least 3 months must pass. 3 to 6 months. So 6 months is optimum. Go ahead with surgery after 6 months. If there is a requirement to operate, then go ahead with between 3 and 6 months. But up to 3 months, please try not to operate on patients who got a drug-eluting stent, and don't stop dual antiplatelet therapy for 3 to 6 months here and 1 month here, okay, with a bare metal stent. Now, having said that, if the surgery is minor, there is low risk of bleeding, or the anatomical site of surgery is amenable to hemostasis, right? For example, a superficial breast operation, then you can even continue dual antiplatelet therapy. So if the patient's condition, the risk of surgery, bleeding is low, and the surgery is superficial, easily amenable to pressure and bleeding and compression, and the patient has a stent with dual antiplatelet therapy, continue dual antiplatelet therapy. Right? Now, for non-emergency surgery, you need to stop because there is a high risk of bleeding, it's major surgery. So Now, this is a new sort of recommendation which is there in the up to date and which has got data which is relevant up to November 2021. So at least 6 months you should defer surgery, right? Whether it's a drug-eluting or a bare metal stent. For time sensitive, like cancer surgery, right? Or some types of vascular surgery, at least 3 months for bare metal stent or drug-eluting stents for time sensitive. If you have to operate, give a 3-month gap. And if you're really desperate, you really have to operate, 1 month is maybe safe. Not as safe as 3 months or 6 months, but you could try and go ahead within 1 month. But what should you do? You must continue the aspirin. So you can stop the clopidogrel or ticagrelor, but you should continue the aspirin. How should you stop the platelet antiplatelet drugs? The clopidogrel and ticagrelor for 5 to 7 days, prasugrel for 7 to 10 days. We have even used stop ticagrelor only for 2 days pre-op, right? So it all depends on the nature of surgery, the urgency of surgery, and the type of drug which the patient is using. And ideally, surgery should be performed with 24-hour interventional cardiology cover. Okay, so that's for dual antiplatelet therapy. Another group of patients which we are getting more and more is patients who are being anticoagulated, right? And of course, warfarin is most common, and the conditions are patients with artificial heart valves, atrial fibrillation, DVT and PE, and other thromboembolic events. So again, in the post-COVID situations, we are seeing patients coming up with high on being anticoagulated for whatever reason, right? So now, when patients are being anticoagulated for atrial fibrillation, right? So then the risk of getting a stroke is given by the CHADS-2 score. And the importance for this for us is that if we are going to stop the warfarin, we must know whether we can just stop the warfarin and operate when the patient is lost the anticoagulant effect of warfarin, because then so as you stop the effect of warfarin, the patient has a higher risk of stroke. But if the risk of stroke is low, the CHADS score is about 2 or 3, then you can just stop the warfarin and forget about it and restart it after the surgery. But if the patient has a high risk of atrial fibrillation or a high CHADS score, then you need to do what we call as bridging with warfarin, and we'll talk about that. So again, when the patient is on warfarin and he's planned for surgery, you should get the INR down below 1.5 to reduce the risk of bleeding, and you should enable anticoagulation after surgery to reduce the risk of thromboembolism. So again, it's a balance between risk of bleeding and the risk of thromboembolism. Right, and there are surgical procedures and patients who are at more risk of bleeding. As far as warfarin is concerned, okay, we know it reduces the levels of factors 2, 7, 9, and 10. And the longest acting, this one is factor 2, which has a half-life of 5 days. Right, so if you stop the warfarin for 5 days, all factors will be depleted and the INR will come down. And essentially, in a patient on warfarin, if you stop the warfarin, the INR will come down, but that will take 5 days. If you want to bring the warfarin down, the anticoagulation down faster, you give oral IV vitamin K. And if it's urgent, then you need to give factors which are active, either by giving FFP or now what we are getting is prothrombin complex concentrates or activated factor 7. So how do you do elective surgery? So this is on day 1, you stop the warfarin, okay? And we know do the INR daily. And usually in 5 days, the INR will be less than 1.5 and you can do the surgery. If the patient has high risk of stroke, you got a high CHADS score, then on the day 3, right, you start bridging with by twice a day low molecular weight heparin. So you replace the warfarin with low molecular weight heparin, and then you stop the low molecular weight heparin 24 hours prior to surgery. If you're giving heparin, standard heparin IV, then you stop it 6 hours prior to surgery, and then you operate. And once you finish the surgery and the bleeding is stopped, on the same day you can restart warfarin. On the next day, you can give prophylactic dose of low molecular weight heparin. And then on the 2nd or 3rd day, begin therapeutic dose of low molecular weight heparin. And when the INR reaches 2, because you're giving warfarin daily, you then stop the low molecular weight heparin. So that's how you sort of handle the anticoagulation. A lot of patients are taking the newer anticoagulants or the oral anticoagulants, dabigatran, rivaroxaban, and apixaban. And we won't go into all the details of all these drugs. But if these have to be done, then then you need to stop dabigatrans 5 days before surgery, You need to stop the apixaban 2 to 3 days prior to surgery. So these are the sort of, you need to keep a gap. So 2 to 3 days for apixaban and rivaroxaban and 5 days for dabigatran. It's difficult to know all these, keep track of all these new drugs and things that come out, but the Astra app is an extremely good app, free to download. Please download it. It tells you what to do for neuromuscular, for neuraxial blocks and other blocks, and you'll get similar recommendations for surgery as well, right? So do that. So at the end of the day, we have to identify and reduce the modifiable comorbid risk factors. The problem is the way we practice, both in private practice, in nursing homes and in institutes, is that the patient comes up for a pre-op checkup 1 week or 2 days or 1 day prior to surgery. At that time, it is very little time to investigate and take care of all comorbidities. And that can sometimes be a problem. So, in private practice, patient will say that to postpone kiya, patient bhag jayega. In institute, will say you're wasting theater time, you're disrupting the OT schedule. So always it's a problem. So what we need to do is we need to change the way we work. And that's probably going to be more important and help us optimize our patients even better. So this is what we normally do, right? The patient comes for surgery, someone decides to operate. Large surgery karega. We are scheduling the patient for surgery on day after tomorrow. So today, let's send him to the PAC. So he goes to PAC, and that's when the whole chakkar starts. And there's hardly any time to do anything. What should happen is that as soon as you think of surgery, you think this patient might be a surgical patient, start the prehabilitation, start stratifying the risk, start looking at his comorbidities, start prehabilitation, give him some time. By the time you work him up, get all his tests done, he started his prehabilitation, then send him to the pre-op clinic with already things on board and optimization process started, and then you take him for surgery. So you have to re-engineer your sort of pathways, right? So I'll leave you with this, and thank you for listening. I'll be happy to take questions, especially on specific problems. I'm sure there'll be many. Thank you.
Thank you, sir. A very nice lecture. We have many questions in the chat box, and Anju madam already given answer to the many questions. But we will discuss here also these questions. Most of the investigations are done in fear of medico-legal issues, and these questions are also related to the medico-legal issues and the blame game that is given to the anesthesiologist and the infrastructures available at our places in the small hospital and the resources available. First question is there, what is your opinion on doing routine coagulation test before CNB? If yes, which one?
I would not advise routine testing for any coagulation testing before a central neuraxial block in absence of risk factors. Risk factors would mean probing the patient for any bleeding tendencies, for any bruises, liver disease, patients on anticoagulants, known bleeding disorders. So apart from that, there is no indication that that is needed for.
Then testing is reserved for the specific and selective group that have comorbidities.
I couldn't. Can you please repeat the question?
No. This is that was not a question. That means the answer is my conclusion is that testing is reserved for the group of selective patient with comorbidities. That
Yes.
means not
Anju,
all patients.
Anju madam, what I want to ask is, suppose the patient is high risk for the surgical bleeding may occur. The patient is high risk for that. So in that case, do we do the coagulation testing?
No, because when you look at the evidence in literature, they have even quoted up there that even neurosurgical cases where risk of bleeding is high, but there are no risk factors underlying in this patient which can suggest increased bleeding. There is no role for it.
Okay. So even if the patient is a high risk patient for bleeding during surgery, we need not do the preoperative coagulation testing because it will not change. But suppose the patient is already having some bleeding disorder, which is not yet come to light. And still we should not do preoperative coagulation testing.
I believe, most of the times, at least in my institute, that is what I have over the years gathered is we order investigations because we fear that we haven't probed our patients enough. We haven't done enough of a pre-anesthesia evaluation. And especially, in setups like ours, where a pre-anesthesia evaluation is done in the evening of just before surgery, the resident is doing it, I'm on the phone, I'm just, placating my fears and ordering a battery of tests, which will not give us the correct information on the patient. So we need to move towards, and as Dr. Devatia said very rightly, we need to change our pathways. We need to actually be in contact with the patients quite early on, so that that kind of confidence building is there and the patients do not hide things from us. And we really get to know. I don't think there should be any kind of, as Dr. Balabhaskar also stated, if there is a guideline that says that in the absence of any symptomatology or risk factors, there is no need to, be testing it. And if the patient does, eventually happens to have some kind of a occult bleeding disorder, I would say, we still have a guideline supporting us in the court of law.
Yes, so the guidelines, Indian guidelines, when they will come, will they support us in the court of law if there is a medical legal issue?
So guidelines are basically meant to guide, they are of course subject to what a sensible doctor at that point in time would be doing. That's how court of laws look at it. But yes, definitely it does give you an edge. Dr. Balabhaskar, your comments, and Dr. Devatia's also.
Yeah, Dr. Nita, with continuation of the discussion, the previous question about routinely advising tests for anticoagulation or a patient who has got a high risk of bleeding in intraoperative period. So when we say that a patient is ASA 1 and 2, basically, so we know ASA 1 is otherwise asymptomatic physically and psychologically, everything. Patient is fit for the anesthesia and surgery. And ASA 2 is also well controlled with a mild disease only, basically as per the ASA statements. So if the patient has got a clear-cut history, for example, patient says there is passing high-colored stools, okay, the patient, there is a history of some bleeding with the small injuries. So only if there is a specific history related to some pathology, number one. And number two, patient is on, for example, specific anticoagulants. So there is a need for some of the advice on like APTT and PTANR. And otherwise, even if the patient is going to undergo a major surgery where there is a lot of risk of blood loss in the intraoperative period, but otherwise in ASA 1 and 2, there is no need to advise the coagulation profile. And even for major spine procedures or where you want to give spinal anesthesia to the patient. And even if you talk about a patient with, for example, fresh bleeding related to an obstetric case, okay, so we have no issue with respect to the patient. So I'm not talking about something like HELP syndrome developing in a patient and other things. So otherwise fit patient, if the obstetrician feels that there is a prolonged labor and failed induction and other things. So, and they anticipate some, so tone will not improve early and there is risk of PPH and all. Even there are situations where definitely there is no role for getting an anticoagulant, coagulation test in the preoperative. So this is for clear. And when we talk about the court of law, all of us are definitely scared and we must be scared. But the thing is, the feedback we have got from across the country is whenever there are some medical legal issues and people go to court, one of the questions that is asked by the judges basically, of course, the patient's lawyers will always be against the doctor, including us. But the judges would always ask, what is the guideline from your society? You are all learned people, you say you have got big association and all. This is not just for anesthesia, it is applicable to all the other societies. So they say you tell only European guidelines and American guidelines, why you don't have such a big population and all. And these guidelines should guide your practice. So based on this, we need a guideline. And if I say in the court of law, even if there is a cataract case, one of the questions was related to cataract, where a battery of investigations are advised. For example, a 70-year-old man, he is otherwise comfortable, he is a chronic hypertensive, he is a diabetic also, and he is for a monitored anesthesia procedure. I can very well say, based upon the guidelines, ASA 1 and 2 patient, he is for a low risk surgery and it's an elective procedure, and I don't want a CBC for the patient. If unfortunately there is some catastrophe, patient goes into complications or there is mortality, and if indeed the patient's attendants go to court, I can boldly say, yes, he fits into this criteria. He doesn't need further investigations. So that is the first step. And if it is so, definitely the opposing lawyer will not question this part. He will go to some other point for discussion. He will say, you have not done this, you have not done this and all. This is the way it goes. And before that, as we said, we should go back to the pre-evaluation, which, for example, for cardiac condition, Dr. Divatia was speaking about. We are more responsible and will be seen as more responsible if we do a thorough pre-anesthetic evaluation of the patient. We jot down all the pre-anesthetic advice on the paper, our opinion, everything perfectly. The perfect record keeping will help us overcome these problems, especially if, as I said, the guidelines related to investigations are followed perfectly. Our anesthesia management is followed perfectly. Still, the opposing lawyer always tries to find a loophole and mistake in our management. So it's a matter of change in mindset amongst ourselves. And again, as Dr. Hemant Shinde was pointing out about the use of echocardiography in the preoperative period. It has been one test, pre-op testing, that has been highly abused in the last 10 years, especially. It's a resting status of the heart, and if the patient doesn't have any functional limitation. So most important thing we should assess in the preoperative period is functional limitations. We need not even go to a CPET. CPET is specific for important procedures, major procedures, and it is very costly. So very simple bedside test we can always do is do a breath holding test for a patient. If you get a breath holding test, it's going to reflect both the cardiac and the respiratory components for the patient's status. And if you find that the patient's breath holding is less, so that gives you a hint that something is not good. So these are some clinical assessments. Based on that, we can give the advice on pre-op investigations. And I don't think we should be scared about the medical legal issues, because anyway, the opposing lawyer who has decided, the patient has decided to go to court, opposing lawyer is always there to support the patient and the attendants, and we are always liable to be questioned. So what saves us is following the guidelines, number one. Number two, putting all the data, thorough pre-anesthetic evaluation, record keeping, time to time, pre-operative, intraoperative, and post-operative period. That's the one which is going to save us. And beyond that, of course, we should be using our own knowledge and fighting the case. That's my opinion. Dr. Divatia?
Anita, can I?
Yes, sir, please, please.
So, you say, what is this medico-legally correct? And I think the key word there is medical, right? So if it is medically correct, you'll also be legally correct. If you're medically wrong, you will be legally wrong. So in a patient who is ASA1, who is otherwise fit and fine, and you've given a spinal and there's some problem, it should be okay if you've not done the test. But if you missed a history of bruising or missed a history of increased bleeding when his tooth fell off or during dental extraction, then you'll in deep trouble, right? Secondly, even when there are no guidelines, let's say as of now, today there are no guidelines, tomorrow I get sued. My fate is going to be decided by what is called, see, you can't prevent, like Dr. Balavaskar, you can't prevent anyone from suing you. It is their God-given right to give abuse and give galis and sue and take someone to court. You can't prevent that. You will be harassed for 1 year, 2 years, 3 years until your case is solved. It's a very unfortunate part of our legal system and our society, right? But whether you will win the case or lose the case, right, will depend in this situation on what the court holds is called a Bolam test, is what a average reasonable anesthetist would have done in the same situation, right? If I do something wrong, my standard will be held as that of a tertiary level institute. Someone who's doing it in a very small rural hospital will be held to the standard in that sort of area. And the person who will decide is the professor and head of department of anesthesia in the nearby medical college. So please maintain good relationship with medical college professors. Okay.
Really a good advice, sir. And in the chat box also, Dr. Anju and Dr. Hemant also had advised that the medical legal problems usually occur not because of not adhering to the guidelines regarding the investigations, but because of failure at some point to give the standard of care to the patient, or maybe having a poor infrastructure. So because we are afraid that our infrastructure is maybe not good enough, we are ordering a lot of battery of investigations to see whether the patient is having something which we have probably missed. So, yes, Dr. Marshall Gatkar has raised his hand. Please unmute himself, Akhilesh. Yes, Dr. Gatkar, you can ask your question.
Madam, is it true? Thank you very much, sir. All of the faculties. Just a question: is it true for the ANC patient also? All the things you are saying that you should not go do the coagulation profile. Is it true for the ANC patient also, or is it mandatory for the patients who is pregnant and is going through the ANC period? Are you getting me, madam?
Sir,
Yeah.
you want to know what this is
For
true
pregnant
for the
patient.
ANC patient? Okay, yes, ma'am. Yes, ma'am, please.
Yes.
So basically, the same guidelines will hold true there. We know that our pregnant patients are ASA2, a young, healthy, no comorbidities patient is a ASA2, right? And then, of
Right.
course, we really need to look at their antenatal history and delve into it. Do they have features of, as Sir said, easy bruising or high blood pressure recordings, headache, and all of those, which is suggestive of any underlying additional, comorbidity in addition to pregnancy. In those circumstances, we may perhaps tailor our investigations depending upon the underlying problem. But for an ASA2 normal pregnant parturian, the same guidelines hold true. The same testing guidelines.
Ma'am, even though she is having a eclampsia, pre-eclampsia, you may say she,
So
her blood pressure is
Pre-eclampsia, I would actually then order a serial platelet count, which is of more important value than an INR.
Okay.
If severe preeclampsia or help, definitely a coagulation testing is warranted.
Okay, but I underwent a case where 5 days back, ANC patient visited a gynecologist. Everything was normal, and during the period, she developed an infective hepatitis. She landed up in a bilirubin like 5, 6, and then we got many complications, bleeding profile, and then they sued the case on gynecologist also, not on me, but they're saying why you didn't ask us the routine coagulation profile when it was deranged.
How will a routine coagulation predict a hepatitis? That is what a question.
No. That the case is still going on, but ideally, at least we should go for the baseline coagulation profile or something. Is it not going to benefit you?
Dr. Dhananjay, then they will say you didn't do something else. So,
yes, sir. That's what.
So
that's why
this is harassment and nothing else. And there are some lower courts and consumer forum who will also give stupid judgments, and it will be a lot of harassment. But at the end of the day, if you've taken the right medical decision at some stage, right, whether it's 1 year later, 5 years later, or whatever, whether it's in the National Tribunal or in Supreme Court, you will eventually get justice. But yes, it is a fact that it is a tool for harassment, and we will get harassed. And it's a very unfortunate
things happening, sir.
Live with this kind of society and this kind of harassment. But it's a fact.
But as
very common, but it does happen.
Unless and otherwise it is somewhat clinically related, you should not go for the coagulation profile.
Otherwise, they'll sue you for charging, making you spend too much money. They'll do that also.
Thank you.
Yes.
Thank you, sir. Thank you, madam. Okay.
Sir,
yes, doctor.
How to proceed if patient having a gestational thrombocytopenia with platelet count less than 50,000?
Usually gestational thrombocytopenia will not have a platelet count as low as 50,000. There would be definitely an underlying comorbidity or an illness along with that has caused a drop. Gestational thrombocytopenia would be somewhere around 80 to 1 lakh, where an expert doing a single short spinal is okay to do. Go ahead with it.
Okay, thank you.
Avinash,
Hello.
Hi, Dr. Hemant Shinde here.
Good evening.
Hi, Jiggy. No, I just wanted to comment about something which is not a particular question to anybody, but I'm reading the chat box and a lot of questions have been asked about medical legal issues facing.
Yes.
You rightly said, if you are right medically, you have to be right legally. That is right, absolutely. But at the same time, many people are worried who are working in Mofussil areas where the infrastructure is not good. and a lot of questions being asked about the infrastructural inabilities leading to mishaps, whereby they are worried that the anesthesiologist will be hassled. And how do we go about it then?
So Hemant, again, if I can answer that. So again, the test is what I said in law, the test is the Bolam test, is what an average person in that situation would do or not do, right? So if you have a terrible preeclampsia, eclampsia, cesarean section in a mofussil area and you deliver and there's postpartum hemorrhage and there is no blood bank and
there is no ICU.
And there is no ICU, and even if there's an ICU, there is no blood, right? So what are you going to do? And there's no FFP and there's no factors. I mean, what are you going to do? The patient is going to die. If they go to court, I mean, there's no chance that they will lose the anesthetist or the hospital will, no chance that they'll lose the case. But there is nothing to prevent the public from bashing up the doctor, burning the hospital, and harassment and bad press and newspaper anchors coming and TV anchors coming saying aisa kaisa hua. That is the unfortunate aspect of the society we are living in, right? But otherwise, as far as the law is concerned, I don't think there is a legal issue in Bombay.
Yeah.
If in Bombay this happens, that there's a difficult case and you don't transfer, you operate in your own chota nursing home with 5 beds and no blood bank, you don't transfer to the nearby hospital, then you're in deep trouble. Yes. But if this happens in a mofussil area, I don't think legally there'll be a trouble. Socially, there'll be lots of trouble.
Okay, thank you, sir. What about the post-COVID patient? Which investigations to be done or in post-COVID patient for major surgery?
So let me tell you what we are doing. Okay.
Yes.
So, and earlier we were very strict, but now we started becoming a little lax about it. But everyone used to get, so if they were not on oxygen, if they're otherwise well, but all they had was fever and did not require oxygen, all of them were still having a chest X-ray being repeated, an ECG being repeated, and a 6-minute walk test being done. Yeah. If they had been on oxygen or if they're going to undergo major surgery, like major abdominal or thoracic surgery, they had to get a CT scan, right? In addition to all these things. And some might get and then we would also do, in all these patients, we would also do a troponin and a D-dimer. Now, and then we didn't know what to do with some high troponin values and we didn't know what to do with high D-dimer values, sometimes 6 months after COVID and patients were otherwise fine with a very good effort tolerance. We went ahead and did some of those cases and we didn't see anything happening. Now, this is experience, anecdotal, we haven't yet got a, but I think the only thing, you need to make sure the patient is asymptomatic, because some patients have that feeling of exhaustion and tiredness and breathlessness after they've recovered from COVID. So you need to make sure that that is not happening. You need to make sure that, they're able to complete a 6-minute walk test reasonably well without desaturation and without getting tired. I think that's a simple sort of screening tool that can be done. Now, patients who are feeling weak and tired and exhausted will not be able to do a 6-minute walk test, but then they probably should not be subjected to elective surgery either. Yeah. So I think, and patients who had cardiovascular instability, those who had oxygen or ventilation should have that ECG, echo, and troponin, and a CT scan of the chest. But otherwise, we are now coming back towards what Dr. Anju was saying, treating them almost like a ASA 1 to 2 patient. But for some time, we were actually being very, very cautious. Now, we have done over 500, 600, 700 patients like this, but I think we are reasonably okay with it.
Actually, may I come in, Dr. Bose here?
Yes, sir.
Yeah, so with respect to the COVID status, the patient being an ex-COVID patient. So we still stick to the basics. Number one is if the patient has continuing symptoms, so which were a new onset symptoms after the COVID infection, if the patient has got that salient history, we must be taking, and then based on that, we can order any investigations for the patient. Number one. Number two, much of the second wave, the mortality was more related to the cardiac events. So that we have to keep in mind. So cardiac events being greater in the second wave, and deaths were also more because of cardiac events in the second wave. So keeping that in mind, if the patient has been put on a long-term anticoagulants because of dysrhythmias and is on cardiac management. So definitely we can take a call on advising on anticoagulants and the cardiac related investigations. So that we have to keep in mind, because we don't have hard data and evidences in terms of very good numbers of patients post-COVID undergoing major surgeries or intermediate or minor surgeries. So what would help is a thorough history taking for the patient, definitely. And if there were any persistent symptoms or continuing low-grade symptoms, and the patient is started on new drugs. New drugs means the patient was not on drugs for cardiac events in the pre-operative period, pre-admission COVID, and he has been started on that, we can take a call on that. Mainly because we are bothered about the thromboembolic phenomena. So that's the one which was the most dangerous thing. So we can focus on advising anticoagulant, coagulation testing for the patient. That is number one. And secondly, there was a question about is there a difference between a rural setup in terms
and
of
urban setup
guidelines? So what I would like to say is we have taken extreme caution here. What is discussed in the guidelines is about routine investigations. When you talk about routine investigations, let me restate that investigations which are done for ASA 1 and 2 patients based upon elective status of the patient's surgery and based upon our assessment. So it is the minimum investigation. Other way to put it is minimum investigations that has to be carried out in these patients. So there is no differentiation between a rural setup or a corporate setup in this regard. So whoever has got such conditions, definitely they must undergo or not undergo some of these tests. So that will definitely be helpful for us to protect ourselves medico-legally and otherwise, and academically speaking, definitely we are protected. So there is no difference here. And in fact, we came across some evidences related to ultrasound. For example, why I am trying to tell is an ultrasound investigation in the pre-operative period. So we have got ultrasound available in majority of the bigger places now, and it is yet to permeate into the smaller hospitals and smaller setups, mainly because of the monetary constraints. And the PCP and DT Act is always a hindrance everywhere. But it's a matter of time. In a matter of another 4 to 5 years, maybe it will become a routine investigation available at a lower price also. So at that time, the ultrasound would also become a routine advice. So that's why we have also taken care to talk about ultrasound in our the guidelines, but we have not made it binding. So there will be a statement, there will be some discussion, but definitely we have taken care to see that there is no suggestion or recommendation related to the use in our guidelines, because that will put our practitioners into risk of medical legal issues. So all these things will be considered when these are being framed, and definitely they are for the practitioners and they are minimum things. Anything beyond that, it is left to us to decide. And if somebody is doing more, he has to explain. If somebody raises an issue that a costly investigation has been ordered unnecessarily, it is for you to defend, because it is not advised by the guidelines.
Yeah, and another thing I believe is that if you're in a rural setup and you have a patient who has multiple comorbidities, is actually into ASA 3 and 4, and your facilities do not support that kind of monitoring or perioperative care, it is advisable to shift the patient to an better, higher center.
Tertiary center.
Yeah.
Take an early call.
Yeah. I think there is no question in chat box now. Yes.
There is one question. The question is really important. Sir, you said correctly, Balavaskar sir, you said correctly that functional evaluation is more important than any investigation. But what about in cases where the functional evaluation is not possible? Maybe because of disability, maybe patient is not able to walk. Anju madam has answered that stress echo can be done in such situations. But if that situation is, if stress echo facility is not available in that particular setup or in that particular city, and then how that case will stand medico-legally if something goes wrong, if stress echo is not, that is one thing. And should we go ahead if we are not able to assess functional evaluation of that patient by just doing the resting to echo? These are the two queries.
May I take it first and Dr. Divakar?
I'm not answering the question, but I'm saying first you decide what is medically correct. Then you decide what is medico-legal. But first, figure out what is the right thing to do medically. Yeah. Now someone will sue you. That's a different matter. Yes, sir. Please go ahead.
Okay.
Yeah, that's perfectly correct.
So,
Right.
I go back to the breath holding test. Maybe I'm overstating about the breath holding test, but it is a simple preoperative evaluation. So if a patient has got a breath holding, a typical breath holding test, which we advise. So the patient, whether it is a cesarean section patient or it's a non-cesarean patient is able to hold breath for about 20 seconds comfortably. Definitely, the cardiorespiratory factors are working optimally. Okay, the test, it's a test we are performing, and history-wise, patient doesn't have any symptoms suggestive of shortness of breath or which is affecting her functional limitation. Definitely, we can definitely say that the patient is fit for our anesthetic management. But going back to actual investigations, yes, definitely ECG, a resting ECG will not reflect anything. A resting echocardiogram will not reflect anything for the patient, except it's a pre-diagnosed condition, and pre-diagnosed condition definitely will have symptoms and signs. Okay, and the patient has got orthopedic disabilities or arthritis, and I think the patient will not be able to do a stress test also, including treadmill test and other things. Tests. And what we can do is, it is required, and if you are in a cardiac setup or in a corporate setup or a bigger hospital, we can have stress echo also being done. Okay, stress ECG is done, stress echo is done using pharmacological techniques. So no physical stress is allowed in such patients. So if it is indeed decided to be done, it can be done using drugs. Definitely, we have got the pharmacological challenge test being done for both the conditions. So we need not worry about that. And if such conditions are there, and if you are not sure, if you want to make yourself medico-legally safe, definitely, as Dr. Anju Madam told about few minutes ago, it is always advisable to have cross-consultation, get a cardiologist in, and if necessary, the patient is advised to be referred to another center where it can be taken up, and you are not sure of yourself in your own setup. You should not be taking risks in modern world where there is a risk of these legal issues.
yes.
But actually, the problem is all the physicians.
Madam, last question.
Yeah.
Madam, once again.
Yes, Dr. Dhananjay, yes, sir, please.
Yes,
Please
yes.
go on.
Madam, just want to ask a question. A patient got normally delivered or a cesarean section, got a peripartum cardiomyopathy, and started failuring. What a anesthetist can done at that place only before shifting her to a ICU setup?
We need to, optimize this patient as per our resources, ensuring that we are actually basically.
What are the, madam, one more question. What are the signs that you can see that this is the patient of peripartum cardiomyopathy? Is there any specific things that we should know? Only saturation is dropping down and they are looking for something else. And you should be sure, because you don't have the 2D echo there. Many nursing centers are there. So what are the things to diagnose, and what should be the things to optimize the patient till patient reach ICU?
So I believe a kind of a resting tachycardia with dyspnea, ongoing breathlessness. Of course, there could be auscultatory findings in the form of fine crepitations coming in. You need to now look at this patient at her, you need to keep her in isobalance, look at her ABCs, stabilize them, and perhaps under monitoring, take her to a higher center. And of course, needless to say that at the same time, you can do a cross consultation with an obstetric cardiologist or a cardiologist, whatever may be the case, and start optimizing the patient.
What can we do at that place?
Dhananjay, I had a case. That's why I'm interjecting between yours and Dr. Anju's talk. I had a case. I know this is the last question, Avinash. I'll answer this and then you can stop it. I had a case. I was doing a cesarean section. Patient was apparently perfectly all right. But in hindsight, when I asked the gynecologist what was wrong, she said every time she used to come to me and used to complain about dyspnea. But I ignored it because I thought it was just a usual thing that most of the women apparently suggest to the gynecologist. Nevertheless, on table, I gave a spinal cesarean section was going on. She started coughing. There was a hypotension. There was a tachycardia. SAT started dropping. I realized there was something wrong. I realized it was pulmonary edema. I had hardly given any fluids to her. I intubated on table, put her on to the ICU because thankfully I was working in a tertiary setup. We did a post-op echo. It was 10% ejection fraction. Actually, I could have lost the patient because I had given on 10% EF, I had given a spinal anesthetic. She would have died on table. Luckily, we started LASIX and the works digitalis. She went home after 7 days. I'm telling you because you are projecting something which is absolutely a difficult case to know it. Either you come to know on table or after it has happened. So it's very difficult to do any investigation for that. You have to stabilize in whichever way, best way you can, and take her to the tertiary center as Dr. Anju has suggested.
So Monisha, up from your question about echo and stress cardiography not being available, I think if it's a pre-op sort of thing that you're looking at, I think a simple thing to do would be to advise the patient needs a stress echo or a pharmacological stress test and say that this is available in the whatever city or town where it's available. And if the patient doesn't do it or cannot go or doesn't want to go or does not heed your advice, then you say that you advised and the patient has not done it and insists that he wants to go ahead with that sort of thing. But so, I mean, when everyone talks about medical legal and all, I mean, always remember documentation is one thing which is extremely important. That I think that's one thing which we are always very lax about. And everyone's worried about medical legal, but no one wants to write their notes in detail. And no one wants to make, keep these things, you know, that you've discussed this with the patient, you've discussed with the mother, brother, father, whatever, and they have refused and or they have said this and they have said that or whatever it may be. And that you've phoned up 3 cardiologists and they don't, and the cardiologists have said that the stress test is not necessary, whatever, but document each and everything. And that will, the other thing that will help you. If you've done something wrong, you can always take out that piece of paper, but make sure you've written the right things.
Sir, may I ask a question?
Actually, what happens?
How will you differentiate a pulmonary embolism and a pericardial, peripartum cardiomyopathy on table?
It's
How will you differentiate it?
Very difficult. On table, very difficult.
If you have pulmonary, it's more likely to be myopathy. If it is just hypoxia, and hypotension, it's possibly more likely to be embolism. But there's, like Hemant said, there is no way of being certain unless you have got bedside echo. If you got bedside echo, it's very easy.
So then, on peripheral anesthetist, what they should do?
If not to the tertiary can
do what Hemant did: intubate, ventilate, keep the vitals up.
Okay. Thank you very much, sir.
Yes, you can
do
supported treatment. Actually, the situation is reverse. We don't want echo, but the physicians are advising echo and they are doing it. And I mean, the patient when comes to us, he has come with echo, everything. And even if we just do a plain physician's reference, we will advise in their advice that this patient needs echo. Though even if we don't want it, the physicians write that. So what we can do when the physician himself is saying that this patient needs echo in that situation?
Even most of the gynecologists do it in PIH and morbidly obese or obese patients.
So if someone has done an echo, there's no problem.
The other way to look at it is, if you really want to come down on that and you feel it is an unindicated echo, perhaps take all of them into all stakeholders into the loop and do some education. Perhaps you can have a shared decision making next time. But if it is available, as sir said, it's okay with us.
No, it is not available. They advise it on paper that this patient needs. And then they ask you to advise, that, okay, get the echo done. They solicit it.
Someone has already asked for an echo, no? Let them do it.
Yeah, exactly. Let them do it.
Thank you, everybody. Now it's 9:10.
Now, Dr. Anita, if the situation is such that physician advice, but for some reason it is not done and patient comes on table,
I know.
And then you say, "Nahi, theek hai, main de deti hai." But then I don't know what the situation is. Then you talk to your professor of anesthesia and medicine in the medical college there, right? But again, I'd say if it is not indicated, it is not indicated. You are well within your rights to say, okay, I will give it. If you think that there is a necessity beyond what the physician has written, if you think there is a necessity and it's going to alter some outcome or management of players, then you should go ahead and ask for an echo.
Both ways, sir. We did not wait for the echo advice by the physician, and we can also advise afresh if we feel it is indicated.
Yeah, there is a very interesting question in the chat box which says, is it medical legally advisable to take a medical consult before anesthesia? You know, so I don't know. I wouldn't say that it is medically legally advisable, but I think that's what a prudent doctor should be doing at that point in time is what is to be done.
It's a good medical practice. The patient has comorbidities, have someone optimize them, treat and optimize them. So it's not medico-legal, it is medical. It is medically advisable to have a physician treat important comorbidities.
Right.
Gray area still.
We had a fantastic session and it is almost 2 hours. We are discussing with so many queries in the chat box. I think we will need a complete day for the discussion on such topics with everyone having different experiences.
You need a lawyer and a medical legal expert on the panel.
Yes.
Absolutely.
Next time, definitely.
We'll have to end this session now.
This list will not, this discussion will not end as a list of investigation will not end. So we will stop here. Thank you, Dr. Diwatiya sir and Dr. Anju madam for their excellent guidelines and guidance regarding preparation, pre-operative investigation to be done and prehabilitation. Thank you, Dr. Balabhaskar sir, for their expert comments. Also, thanks to our president, Dr. Manisha madam, Dr. Anita, Dr. Samir. I also thank to Akhilesh who conducted and controlled this meeting on our Maharashtra State Chapter platform, and most important to all the participants who give a huge response. I think there was link was not available for many of the anesthesiologists and they could not join. So it was a huge response for today's webinar. And this will definitely boost our enthusiasm to conduct more and more such webinars. So I thank you all who joined for the webinar today. I declare this meeting is over. Thank you. Good night.
Thank you. Thank you.
Thank you very much.
Thank you so much.
Thank you.
Well.